Good morning. Welcome to the spring seminar hosted by the University of Michigan Human Research Protection Program, or HRPP. The HRPP and its units hosts a seminar biannually or twice a year on topics related to human subjects research as part of our seminar series. Today's seminar is an opportunity for you to deepen your understanding of the Institutional Review Board or IRB procedures. So during this seminar, you will learn the critical steps involved in IRB pre-review and the review process, tips for preparing a successful IRB proposal, common challenges and how to overcome them, and best practices for IRB submissions. The speakers today will explain their role in reviewing for IRB requirements, share insights, and provide guidance on preparing research submissions. I'm Renitra Reynolds, the HRPP Education and Policy Coordinator, and I'll be providing a brief introduction for the seminar. Some of my colleagues today from IRB Med are also presenting today. Allison Canoes will present on the review considerations for expedited pre-review. Christine Polson will talk about the considerations for full board pre-review. Nicole Robeson will talk about single IRB review considerations. And then she's followed by Kathy Dowling, who is a board member and staff member, and she will talk about the review considerations from the perspective as a board member and staff member for expedited and full board submissions. I will give a presentation on the review considerations that are somewhat specific to HSBS, and then that will all be followed by a Q&A. So this is the organizational chart for the U of M HRPP, which I wanted to show to highlight that the HRPP includes both IRB offices at the university. So there's IRB Med and the IRB HSBS office. And so IRB Med serves the medical school and hospital system, whereas IRB HSBS reviews the health sciences and behavioral sciences research from all three campuses. So that includes Ann Arbor, Flint, and Dearborn. There are a total of 8 boards among the two IRBs that together review all of the research projects at U of M, except for when IRB review is ceded to an external IRB. The HRPP also includes Coordinated Services and Practices, or CSP, the Office of Research Compliance Review, or ORCR, and the HRPP also has additional staff dedicated to overseeing and managing policies and education under the HRPP's purview. So most of the speakers today will focus on their role in pre-reviewing and reviewing applications submitted to the IRB. However, I wanted to take a moment to introduce and talk a little bit about the current system, electronic system for submitting research applications to the IRB. eResearch is the university's site for electronic research administration. It has multiple components to it, and the research application for an IRB submission is completed within eResearch. So the regulatory management component of eResearch is where you will find the applications to complete and submit for IRB review. Proposal management is for processing funding proposals, grants, and awards, as well as other types of unfunded agreements that might include a material transfer agreement or a non-disclosure agreement. The ERAM component is for research applications involving non-human animals. So animal research being submitted to IACUC would go through ERAM. M-Inform is for conflict of interest disclosures. And then MyCores is for requesting access to the research cores to request shared supplies, equipment, instrumentation, access to facilities, and services to help with research. And so Nicole will talk a little bit about MyCores when she talks about the single IRB review process. So you would navigate to eResearch and log in to the regulatory management side in order to complete any application for IRB review. Also, notice the Learn More link under the paragraph um, under the regulatory management header in the middle of the page. So that Learn More link will take you to this page on the right where there's a screenshot of the page on the right. And that is where you can have access to a number of resources on the left-hand side. So first, starting with Getting Started, if you navigate to that link, it takes you to resources for how to log in. There's a pre-application checklist and system requirements, etc. You can also link directly to the glossary, training, reference materials, and FAQs from these links on the left-hand side. Specifically, if you navigate to the reference materials page, you can access spreadsheets that include the questions for the IRB applications. So there's a spreadsheet with the application questions for initial research projects, for multi-site research projects, for amendments, AE Oreos, and continuing review. So you could access those questions to prepare the information before you actually start the application. There are also links under reference materials to various step-by-step instructions by role. So you would navigate to the PI study team member role, and you will find instructions for common e-research activities like creating a new application, adding a new study team member, or working with documents that you will need to upload with the application and how to do that. So next, I just wanted to give an overview of the types of research projects that the IRB review in a very broad sense. So there are exempt research projects, there are expedited research projects, and full board research projects. Generally speaking, there are others. But both exempt and expedited research projects are reviewed by the expedited review process. And by that, we mean that the project is eligible for one member of the board who is qualified to review that project can do so. And so it's only one member of the board reviewing an exempt project or an expedited project in most cases. Then there are the full board projects, and those go to a committee, the full board, for a vote on the approval. And so that process is different than the expedited review process. And presenters today will discuss the considerations for both of those processes. And then, as I mentioned earlier, Nicole will also talk about the single IRB projects. Those projects require, in some cases, a multi-site research application, and that's where U of M is going to serve as the IRB of record, or there might be a request for an external IRB to serve as the IRB of record, in which case a seeding application would be required. And so we will move on now to Allison to present on considerations for expedited pre-review.
Thank you, Renitra.
Sharon, you're welcome.
If I can share my screen.
Mm-hmm.
All right, can you guys see it, the slides?
Yes.
Okay. All right, so I am Allison Knaus. I am a certified IRB professional and a senior regulatory staff on the expedited team within IRB Med. Today, we're going to be going over exempt and expedited review considerations, as Renitra just said. And so I'm also going to touch a bit on not regulated review pathways because there is a little bit of an overlap and vagueness when we start to look into different types of activities that are approved within grants for QA/QI and not regulated projects versus actual studies that are regulated as human subjects research. And then we're also going to touch on some FDA considerations for no more than minimal risk research, which is most likely usually expedited. So exempt and expedited review pathways are used to satisfy the federal regulations pertaining to human subjects research. Both are human subjects research per the regulatory definition. The difference between the two of them is that the exemption categories are exempt from ongoing review. except for anything that could potentially move it outside of its like exemption category. And we'll get into some examples of those. So some examples would be if a researcher was conducting like a sports injury survey and then decided, oh, I needed to go back into their chart to access some data that it wasn't originally approved for. That accessing of that secondary use data is considered an exemption 4 project. And previously, this investigator only had a survey project, which was approved under exemption 2. So adding in these exemption 4 categories to exemption 2 would not be approvable under an expedited category anymore. This would be the same thing if you were trying to incorporate incarcerated subjects or any sort of vulnerable population into your exempt project. So here I have outlined the exemption categories, and I do want to let you know that all of the links that I've embedded into these PowerPoints will be live with the PowerPoints that are shared after the seminar. So you can access our e-research guidance and then also our additional e-research guidance on federal exemption categories. Both of these links go into great detail. The federal exemption category is a little bit more strictly related to how the federal guidelines set it out versus the exempt human subjects research has more information about internal policies as well. So these are the exemption categories. Exemption 1 is usually limited to a normal education practices. Exemption 2 is typically referred to as survey research. Exemption 3 is a benign behavioral intervention plus a survey or questionnaire. This gets a little bit interesting because there's no real consensus about what a benign behavioral intervention is. And so we'll work with you to help make sure that meets the regulatory definition for that. And then for exemption 4, which is secondary use research, this was expanded under the revised common rule. And we'll get into this a little bit more about how secondary use research could fall into a not regulated, exempt, or expedited review pathway. The other 4 exemptions, 5 and 6, we don't really see too much here at U of M. They're very rare. 5 is for federally funded projects or federally sponsored projects that are about public health and benefit. And then 6 is taste and food quality evaluation. Exemption 7 and 8, we don't use here at U of M because we don't use broad consent. All right, so not regulated projects versus human subjects research. So per the university's operation manual, you're not required to get a formal determination of not regulated status in order to conduct those activities. However, in order to publish with a journal, most journals will want to see this determination letter ahead of time, and IRB Med does not offer retroactive determinations. So if you were to conduct these activities and say, hey, I need this determination letter, we would be like, sorry, you can reference the OM that says that we don't require you to seek this, but we can't go back and issue you a determination for something that's already been conducted. And so these are our most common activities not regulated as human subjects research: QA, QI, case studies, public health surveillance, preparatory to research, research involving decedents, coded data or specimens, and de-identified data or specimens. And so the ones with the asterisks and also QA, QI often kind of dance that fine line between not regulated and human subjects research. So when we're evaluating these applications in an expedited review, we're looking to see, is anything going to catch my eye that might pull this out of a not regulated determination? And especially later, we'll get into the difference between de-identified and coded data, and you'll see how this is more important for our secondary use applications. So this is kind of reiterating what I just said, actually, so I'm not going to go through this all again, but our FAQs go into a lot of detail on this. I highly recommend checking them out. There's a lot of information about case studies. Once you go, because at U of M, case studies are limited to 1 or 2 individuals. Once you get 3 or more, you're in secondary use research and you're not eligible for a not regulated determination anymore. And these are our expeditable categories defined as human subjects research by HHS. Exemption 1 is clinical studies of drug or devices, and these are when you do not need to have like an IDE or an IND. Those type of submissions will go to full board. We do have some other considerations about exemption 1 that we'll discuss later on. Exemption 2 is collection of blood samples. Exemption 3 is prospective biological specimens, kind of like nail clippings or like a saliva scrub. And then, we're in expedited, I keep saying exemption, we're in expedited categories. So expedited category 4 is collection of data through non-invasive means, and this does not include I can't think of it off the top of my head. It was in the notes, but this is for excluding X-rays and microwaves. Sorry, those would be considered invasive. All right, so expedited 5, this is secondary use research that requires comprehensive review. So this would be secondary use research that would require an informed consent waiver or a full HIPAA waiver. And then category 6 is collection from voice, digital, audio recordings, video recordings. And then expedited category 7 is research on groups or individuals, characteristics or behaviors. This is our survey expeditable category. We also do interviews under this as well. So what you would see under exemption 2, you could also see following under expeditable category 7 based off the regulatory review requirements. There are 2 other expeditable categories, 8 and 9, and those are for continuing reviews, so we're not touching on them here. Okay, so as I've been kind of saying this entire time, you'll see that there's just a little bit of overlap within the review pathways, and this is due to the federal regulations surrounding vulnerable populations, HIPAA protections, including PHI, and other FDA regulations that would be imposed upon your activities. And so this is where we see how secondary use can be routed down a not regulated coded or not regulated de-identified application type. It could be routed down in an exempt 4.3 or 4.2 or 4.1. Exempt 4.3 allows for recruitment and screening of PHI. And so you would go and it would undergo a limited privacy review for exempt 4.3 submissions. And then if, let's say, you were including something that would require a comprehensive secondary use, and usually this is required by the sponsor where they're saying, no, we need to see full informed consent waivers. And so you would route your secondary use application down an expedited category 5. And so that would be a comprehensive review. Currently at the university, our expedited category 5 retrospective analysis, we would typically apply no annual continuing review requirement unless there was something that stood out in our review that we as IRB felt that it needed an annual continuing review. But effectively, it would work the same for researchers, be an exempt 4.3 versus an exempt category 5 for your working purposes. It's only the submission that you're initially submitting to us and getting determination for that would be a little bit different, the review pathway. And then here's the big thing I kind of want to get across between the difference between de-identified and CODA. So under the common rule, a data set is de-identified only when no one could re-identify the data. That means not the recipients, the data provider, or anyone else. So if there's a code to the key that exists somewhere to anyone, even if the U of M team would never have the ability to re-identify, it's still coded under the common rule. It can be de-identified under HIPAA, but still coded under the common rule. So it's one thing to kind of be aware of when submitting a not regulated, coded, or de-identified application. We typically always ask that you submit a secondary use application instead, because that will populate the scope of secondary use questions that will allow us to arrive at the appropriate not regulated, exempt, or expeditable determination. All right. Oh, so we also see this overlap within survey research. Exemptions 2 for survey interviews, questionnaires, and 3 benign behavioral intervention do not allow for minors to be enrolled. So if you do anticipate, if you have an exempt study with minors, we're going to route that down in an expedited category 7 project. So you're going to have a more comprehensive review for your application. Okay, and so expedited category 1 with the drugs and devices, you have to be really kind of careful about the intended use of potential drugs and devices. The FDA has regulated cranberry supplements, cranberry juice, and broccoli sprouts as drugs here at U of M, and these would all have to go to full board. They typically started out as expedited during the review, and it took multiple rounds of working with the team to really understand how the FDA really wants to look at what you're doing with this product. And even though it might be just a supplement, your intended use for it now is a medical drug or device. And we see this the same with a lot of machine learning models or algorithms, a lot of AI nowadays when we're trying to use it to help the prevention or mitigation of disease. it's going to fall into that device category, even though it's not a physical device as you would think. And so here we have additional guidance on mobile medical applications, and how even if they're not directly connected to the device, but they're hooked up to it, if their intended use is for the diagnosis, cure, mitigation, treatment, or prevention of disease, it's going to be regulated as a medical device. And then this UMIC presentation is wonderful. I highly recommend it if you want to get more into this. This topic can get really nuanced and confusing. I've also included in here a bunch of references for PHI and data privacy support. I've gone through and collected most of our guidance links that I could throughout this presentation. But please feel free to reach out to IRB Med or any of our regulatory analysts for questions on these topics. I know this is kind of a brief overview, but we are happy to help.
Good morning. My name is Christine Paulson. I am the education coordinator of IRB Med, and I used to be a staff analyst for full board submissions for the C2 team. This particular presentation is being done with Julia Ryan. Julia is the staff team lead of the C2 board. Today, I'm going to go over quickly the federal regulations that are for full board submissions, what research requires IRB full board review. Then I'm going to go over details that need to be determined before you start your submission in eResearch. Then I'm going to go over our federal criteria for Institutional Review Board for their new study approval and considerations for each. Here are the big three in federal regulations. I'm only going to be talking about the first two, though, the Office for Human Research Protections and the Food and Drug Administration. The type of research that needs full board review are studies that involve more than minimal risk, clinical procedures with drug devices and biologics, or innovative research into new medical or surgery procedures. Complex research design requiring the expertise of multiple board members to evaluate, research involving deception, or when an IRB analyst, board member, or designee determines that the risks are greater than minimal. Also, research involving vulnerable populations such as pregnant women, women of childbearing potential, prisoners, children, or cognitively impaired. Now, those last two, children and cognitively impaired, the research does depend on the risk-benefit ratio of that research. Here are items that a study team needs to determine before they start their eResearch application. Risk level, benefits, whether an IND or an IDE is required, who is going to be included in the subject pool, your data and safety monitoring, and how you're going to protect privacy and confidentiality. When it comes to risk level, please remember that risk isn't just physical, it's also psychological and informational. And for any study, risk must be minimized, decreased to the lowest level consistent with the study aims and objectives. When you describe risk, please include both the probability and the magnitude of possible harm for each. Anticipated benefits refer to the positive outcomes or advantages expected for participants and society as a result of participating in a study. eResearch will ask a yes and no question when it comes to anticipated benefits, but please know that a yes response will include both potential direct benefit and indirect benefit. And IRB Med needs the risk-benefit ratio as one of the criteria for approval. Then you need to see if an IND is needed. An IND stands for Investigational New Drug Application, and it is required for clinical investigations involving humans when there's an experimental drug or a biological product or an FDA-regulated product which is administered or dispensed to humans. An IND may be needed if the research is a clinical investigation, involves a drug as defined by the FDA, and is not exempt from IND requirements. Now, the FDA defines a drug as a product that is metabolized or acts through chemical action in the body. Beware in assuming you do not have a drug. As Allison said in the previous presentation, nutritional supplements can be viewed by the FDA as a drug. Then you need to see if an IDE is needed. IDE stands for Investigational Device Exemption. These may be needed for clinical investigations involving unapproved devices, especially those posing a significant risk to participants. A device is defined as meeting all of the criteria. It has to fit all the intentions for use. It does not achieve its primary intended purposes through chemical action within or on the body, and it does not depend on being metabolized for the achievement of its primary intended purposes. Beware in assuming you do not have a device. An algorithm can be seen as a device. If you are unsure, please consult with MyApp. They provide consultation on research involving investigational agents. If MyApp suggests submission to the FDA for an IND or an IDE, it is in the study's best interest. It keeps things moving when the submission reaches the board, and precious time isn't wasted trying to figure out the regulatory status. And finally, it leaves no question for both the study team and the IRB because the FDA's decision is final. Also, a study team needs to determine which individuals and possibly vulnerable groups will participate in the research. There are many vulnerable groups listed in Section 9 of eResearch, but the most common groups are children, women of childbearing potential, patients of the study team, and cognitively impaired adults. Now, subject population is used by the IRB to determine who may be included in the research. But by indicating which groups are included in the study design, you are not explicitly excluding subjects that may incidentally belong to other groups. And please avoid including a vulnerable group on a just-in-case basis if the research doesn't actually target that group as potential subjects. The exception to this is women of childbearing potential. If there is a possibility any women of this group might enroll, you need to check that box in eResearch. And if the research involves children, it is important for the study team to determine an accurate risk and benefit level early. Now, federal regulations require that the research plan make adequate provisions for monitoring the data collected to ensure the safety of subjects. And this is generally required when the risk of harm to subjects is more than minimal. Some federal agencies require a data and safety monitoring plan if they are supporting or funding the research. Please note that a data and safety monitoring plan can be part of the protocol or a standalone document, but it should be tailored to fit the expected risk level, complexity, and the size of the study. Study team also needs to determine ahead of time the methods for protecting research records, data, and specimens against inappropriate use or disclosure, breach of confidentiality, accidental loss, or the like. If the study includes the future use of data and/or specimens, you need to determine who is doing what with the data and specimens and what identifiers the data and specimens will have attached and at which steps within the life cycle of the study. Here is the criteria for approval based on OREP regulations and FDA regulations. The criteria are this: risk-benefit ratio, distribution of risks and benefits, consent, protection of vulnerable subjects, and protection of privacy and confidentiality. I will go into each one of these and give some considerations for each. For the risk-benefit ratio, the IRB board will look at, are all reasonably foreseeable risks to subjects identified? Remember, it's not just physical. Risk can be psychological, reputational, legal, etc. And for each identified risk, the study team needs to describe the likelihood of the risk occurring, how serious the risk is to subjects, and what measures the study team will take to minimize that risk. And this is where we do it. Question 6.7 in the application. Everything I just mentioned is listed here. You put all this information in the text field. However, considerations for that text field. It is okay to reference section 5.1 of the informed consent document as long as it also refers to at least a few relevant sections of the protocol and at least a few relevant sections of the investigator's brochure or drug label of the FDA-approved article. When listing the sections of the protocol or IB or drug label, it is permissible to state including but not limited to the following sections. And finally, in the informed consent documents, all the risks should be listed and grouped by frequency. If you use the working version of our consent template, it will guide you to add an explanation of what will happen, and it helps the study team have a plan to mitigate that risk. For the criterion of distribution of risks and benefits, this relates to the ethical principle of justice in the Belmont report. It is the principle that requires fairness in the distribution of burdens and benefits among all subjects groups, and that fairness needs to be based on sound scientific rationale and should avoid exploitation of subject populations of convenience. Questions that the full board will seek to answer are: what populations will bear the burden of the research? What risks will they face? And will those same populations also benefit from the research? Now the consent. Is the informed consent process fully described in section 10 of the application? Please note that the consent process required in section 10 is not the same as the recruitment process needed in section 1-8. They're separate study processes requiring different descriptions. Are all the federally required elements of informed consent present in the document? Again, our informed consent templates include all of the required elements. But if all the required elements are not included, is the study team requesting a waiver for or modification to a particular element of informed consent? And if so, are the reasons for that waiver or modification justified in the application? Does the informed consent accurately and adequately describe the research? If the research is FDA regulated, are all the risks listed in section 5.1 of the consent? That section must have all of the risks and not simply the most common ones. If the study includes children and or cognitively impaired adults, does the study team have plans for assenting these individuals? And is there a good description of the assent process in the application? Is it clear? Does it state which groups will use the consent document, which groups will use the assent, and which groups could have an assent waiver? When it comes to vulnerable subjects, the IRB will look at if including vulnerable subject groups are all additional regulatory criteria afforded by the federal protections addressed in the application. There are 3 groups in OREP regulations as listed here that get additional protections. And in FDA regulations, there are additional safeguards for children in research. If the research does include children, does the required number of parental signatures in the consent correspond with the risk and benefit level? When it comes to the protection of vulnerable subjects, are the study procedures appropriate for women who are or may become pregnant. Pregnancy tests are generally used to exclude subjects who are already pregnant if there is a risk to the fetus. Be sure this measure is stated. If the study drug poses a risk to the fetus or to a person's future reproductive potential, are appropriate measures recommended in the consent. Contraception can be a sticking point in new study approvals. If there are recommendations, make sure they are accurate and backed up by the protocol and/or IB and consistent across the application and consent. For the protection of privacy and confidentiality, are there adequate provisions to protect this? This is usually done in sections 11 and 11-4. And if surveys are being done on computers or tablets, add information about the system being used. There are questions in section 1-2 of the standard study information in research to accomplish this task. What will happen to the data and specimens after the study is done? If these will be used for future research, will identifiable or coded information be used? You must specify that. And if the study is funded by the NIH, please be prepared to upload the 1 to 2 page DMS plan. In conclusion, for research requiring full board review, if the IRB sends the new application back to the study team for changes, and this could be revisions to text fields, asking for additional documents, or asking for revision to documents, or asking for additional sections in the research to be completed, remember there is a regulation requirement behind each requested change. Here are the sources and links to my presentation, which will be available in the slides. Thank you very much.
All right, so now we will go over some special considerations and reminders that are specific to single IRB workflows. My name is Nicole Robson. I've been working with the IRB office for over 13 years, with a majority of that time in some area of single IRB. I now have a joint role between the IRB Med office and the IRB CSP office as a single IRB team lead and a QA/QI specialist. I'm going to go back a little bit to talk about a few pre-IRB application considerations specific to single IRB. When planning to be part of a multi-site project at the time of grant application, there are different steps to take when requesting a U of M IRB letter of support. If you are requesting that U of M IRBs act as the single IRB for a project when it is funded, you will need to submit a single IRB request, service request in MyCore as soon as possible. This is supposed to be done before submitting a funding application. If a U of M IRB agrees to support the project, they will provide a letter of support and budget, if you're working with IRB Med, to be included in the funding application. If you are planning to rely on an external IRB as the single IRB, you may need, or you may be requested to provide a letter of support from the IRB office that indicates they are going to be the single IRB. This letter of support would indicate that U of M is willing to rely on that specific IRB if the project is funded. If you receive this request, you can reach out to your IRB office for this type of letter. The U of M's Health statewide network of care sites, so sites such as U of M Health Sparrow, U of M Health West, Chelsea Hospital, and more, there is a specific working group that helps with these research relationships, and you must submit an intake form and work with this group before starting any research activities at one of these sites. More information about this process is available on the IRB CSP webpage. So when is a single IRB required? The federal regulations indicate that the single IRB model is required to be used whenever there's federal funding that is tied to a cooperative research protocol. This is a protocol that has more than one site and where the separate sites are conducting activities that support the goals of the research design. The other sites could be performing only data analysis assistance on a larger clinical trial, and they would still have to follow the single IRB oversight model. There are some exceptions, though. Research that involves international sites, those international sites do not have to follow a single IRB model. The research protocol that is determined to be exempt, meaning the entire protocol that has been submitted for review qualifies for an exemption. Research that qualifies as not regulated. And then more than one IRB review is required by law. So in most cases, this is a tribal law scenario. When a U of M IRB is a single IRB, U of M is responsible for the regulatory review of the protocol and all the supporting documents. External sites remain responsible for their local context review, and this covers things such as study team qualifications, training, ancillary committee reviews, and review of different local laws or policies. The external sites then report that local context detail to U of M IRBs, and the U of M IRB will perform a review of that site and activate them. After the site is activated, each site will have a continued reporting responsibility to their local HRPP or IRB office as well. Each site is different in how they handle this and what they require. So the relying site study team should work with their HRPP IRB to understand those continued responsibilities. When U of M is acting as the single IRB, there are special considerations to think about when you're going through the initial review process. So for a protocol document, the protocol is to be drafted in a way that is not too site specific when it comes to things such as clinic locations or study or standards of care that may vary between sites. The informed consent document, it must be submitted as a drafted template. Once approved, the templates get made site specific during the site activation process. IRB Med uses a Part 1, Part 2 model for clinical trials, but studies that meet the guidelines to use a specialty template or short form type template can use those templates with fillable fields for the site-specific information. Recruitment documents can be made study-wide resources or template resources that can be made site-specific. A manual of procedures, this may be deemed required by the IRB staff reviewer or board if the protocol is not detailed enough to describe how the procedures are performed and how they are being communicated and handled between the sites working together. And then other study-specific considerations could be surveys or lab manuals. You want to make sure that they're not, again, too specific to one site. And then depending on your study design, you may also be required to submit a separate U of M performance site application, work with your IRB office to determine if this is necessary. When working on these types of studies, it's best to look at the available guidance and resources, and these are available on the IRB CSP webpage. Additional education materials and sessions are being developed, and they will be available soon. Each phased rollout will be announced in a newsletter. Now for seeding and reliance, these are the scenarios where we at U of M are relying on an external IRB. So even when the external IRB is the single IRB, U of M remains responsible for a portion of the review. This portion of the review is called that local context review. For both IRB offices, this includes a review of the members of the study team to check for appropriate qualifications, their research training, and any potential COI, as well as a review of the protocol to ensure that it doesn't need any site-specific changes or modification due to local law or U of M policy. For IRB Med, this also includes review by any U of M specific ancillary committee that is triggered by the design of the protocol or the services used to conduct the research activities at U of M. Ancillary committees at U of M could include, but are not limited to, the Protocol Review Committee, Research Pharmacy, Creo, RDRC, Sure, MyApp, Mishar, Clinical Engineering, and the Tissue Procurement Core. So what do you need when you're submitting this request to rely on an external IRB? You'll have to submit a seated application using the application type request review by non-U of M IRB. You'll need the most recently approved versions of the protocol and informed consent templates that are being used at U of M. If working with the IRB Med Office, you will also need to insert locally required boilerplate language into those informed consent templates. That boilerplate language is available on the IRB CSP webpage. The IRB approval that documents the IRB review of the overall protocol and template documents that are being supported or submitted, and an expiration date if applicable. And then the IRB reliance documents and packet. After the initial request to rely is approved, a U of M study team is still expected to continue to report the following items to the U of M IRB. So if the study qualifies and requires a continuing review, you would submit to the external IRB, but you will also have to submit to U of M IRB. For amendments, local staff and minor edits, minor site-specific edits, that should say, they need to be submitted to both IRBs. The protocol that ICF changes that affect ancillary committee reviews, they need to be submitted to both IRBs. Protocol ICF that does not affect the ancillary committees, they only need to go to the single IRB and not the U of M IRB. The serious adverse events, so you would need to look at the requirements of the single IRB, and then our local requirements would also need to be followed. Other reportable events, again, the requirements of the single IRB, because they vary between the single IRBs, and then those other reportable events would be reported locally if they were required to be reported to the single IRB. And terminations, site-specific terminations would be submitted to both IRBs. There is also additional guidance available on the IRB CSP webpage. Again, additional education materials and sessions are available or are being developed and will soon be available. Each phased rollout will be announced in the newsletter.
I hope you're seeing the slides you're supposed to see. Let's see. Okay, there you go. Please stop me if you don't see what you're supposed to see. So
You're good,
my name's
Kathy,
Dr.
thank you.
Oh, that's good. Okay. My name is
Yep.
Dr. Kathy Dowling. I am a IRB Med reviewer, and I really wanted to focus on some areas as a reviewer that I see commonly that needs a little touch up from the study team. So it won't be quite so academic, except for hopefully you get this sense of what we're looking for when it does get to a reviewer. As you can tell, there's a lot of hard work that goes in even before it gets to a reviewer. The office staff for both full board, expedite, they do a tremendous amount of work just making sure the application is filled out correctly and ready for a review. So my background, how did I get to do this? I was an anesthesiologist until '99. I was home with 7 children. They were beautiful and wouldn't regret it. And then in 2014, I came back and worked with neurology patients in research, multiple sclerosis, Parkinson's disease, and Lewy body dementia until around 2022. And then I had joined IRB Med as a full board alternate reviewer in 2020. And then I joined permanently the staff of IRB Med in 2022. So as we have been told already, and as you know, the reason we're here is to protect human subjects. We ensure we have to do this. We need to ensure we're following the Code of Federal Regulations, which is the basic one is 45 CFR 46, but there are other, FDA regulations, et cetera, that are followed as well. I'm going to cover the 3 areas of reviews that I do. It's the exempt reviews, expedited reviews that Allison talked about, and full board reviews that Christine talked about. So basically, exempt research is not subject to the common rule at 45 CFR 46. There is the section in there that says everything is human subject research is bound by these rules except for a list of those exempt studies that Allison talked about. However, it is subject to HIPAA. If protected health information is included, then HIPAA regulations should be followed, and there would be a limited review, which would go to a reviewer such as myself to ensure that the HIPAA regulations are followed. If it's an expedited research, it's still subject to, it is subject to the common rule, and it is also subject to HIPAA. So those would go to a reviewer. So I wanted to highlight the secondary use studies because I see these quite a lot, these exempt 4.3 studies that Allison mentioned. And there's one question in e-research that kind of dictates which way the application is going to go. And the office reviewer will actually make sure that that has been done correctly before it gets to the review. However, it might be helpful to save a round back and forth. For question, does the source of data or biospecimens require an IRB review and approval of the project, full committee or expedited review rather than an exempt or not regulated? So you would answer no if you're only getting medical information like a MyChart review for certain diseases and some lab tests and things you wanted to see, to learn more about how those were handled in the clinical setting. That would be routed to the exempt review. You'd answer yes if you have medical information, plus you have previously collected identifiable specimens. That is not eligible for an exemption review. It would go to an expedited review. So I just want to say that because that can help streamline things. When you are using protected health information for secondary use, section 25-2 will open up. And this is when, and this is something that I got to say it's kind of important for me when I'm doing an exempt review. It's basically my review is, are you following the HIPAA regulations? And so there's a series of questions that ask about how you're going to handle patient subject identifiers. So 25-2.2 is a one that I usually try to ask the team to clarify because they may not really understand what that question's asking. I remember the first time I filled out a secondary use application before IRB, I just looked at this set of questions and I would say, blah, 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 we'll be careful, blah, blah, blah. But basically, as a reviewer, I see there's more to it than that. So basically, there's two things you can say in 25-2.2. Number one is code your data. A lot of people, they may planning to code it, but they don't say they're going to do it. So I just wanted to point that out. So coding would be something like this, like on one HIPAA compliant software, you might have your subject ID codes and then the MRN numbers and the name. That's kind of a real common combination of things to put. It would be on a separate password protected file that's HIPAA compliant. And then on the data collection sheet would be a different Excel file. You'd have the same subject codes and then the diagnosis, test results, etc., that you plan to get from the chart for your study. So it's an easy thing to say, and that just so you clear, that's what we're looking for. The next part of that really is not to forget to say that you will be using HIPAA compliant devices and software. So any Michigan Medicine computer basically would be fine for that. But some people may not. They may want to use a home computer or whatever. And you have to be careful of what you're doing. Make sure you follow the safe computing guidelines from Michigan. So I have a link there for you to look into that if you need to do that. And the next question is something I just want to clarify something really. This 25-2.3 describe the plan to destroy patient subject identifiers at the earliest opportunity consistent with the research. A lot of teams are saying, oh, we're going to delete all the study data after we publish the paper. Okay, you don't have to delete all your study data. I just want to clarify that. What we would like to make sure is that you are eventually will destroy the HIPAA identifiers that link to your data. And so the HIPAA identifiers are there's both direct and indirect. Most of them that are specified with the HIPAA regulations are the direct identifiers like name, MRN, specific address, a unique identifying numbers like social security number, driver's license, a license plate, things like that that could uniquely identify a person or their family member. And then the indirect identifiers, there's a few of those. And one of those is the subject code that if linked to a direct identifier would be an indirect identifier. Like that code I just, in that example I gave you, would be an indirect identifier. If it is still linked, if you have a spreadsheet where it's linked to the direct name, MRN, or another direct identifier. Also, exact dates are indirect identifiers, city, state, zip codes, things like that are indirect. And so, let's see here. Yes, so this is a little table that I really like to show people. It explains the direct identifiers, and if you're going to de-identify them, you need to remove all of the things that it says on this chart. And if you have a limited data set, then you need to remove up to what they say, but you can include a subject code and dates in a limited data set. So what I'm trying to say is that you need to be clear, like when you want to, delete the patient subject identifiers, to be clear what that means. Because a lot of people say they're going to de-identify the data, but they don't really say what that means. And they may be confused that the subject ID code, if it's still linked, and dates are HIPAA identifiers that need to be removed eventually. All right, I hope that was clear. Like I said just now, you don't need to delete all the study data, just the 18 HIPAA identifiers or anything else that is in your data that you might be able to recombine to figure out who that was. And then for an exempt study, this is not following the the common rule and things like that. So basically, you want to like not maintain these identifiers longer than you need to. So for exempt studies, that would be to delete all of those HIPAA identifiers. And when do you do this for an exempt study? You can follow the sponsor's guidance. If you have a sponsor study that is having you do chart review, then you need to follow their guidance. If there's no sponsor, and then when the data analysis is fully complete, including journal acceptance, then you would delete those identifiers. If you need to retain the link to HIPAA identifiers, you should state the reason and the time frame that this will be done. Some studies, you may, after publication, you may have people wondering about how valid your research was, and you might need to go back and verify that stuff. So you could probably have that in the answer to your question there, okay, when you will delete those identifiers. For non-exempt studies, usually the retention for data is longer. It's usually at least 3 years. It depends on the study, the sponsor, the operation manual for HRPP, the FDA regulations, the common rule, and HIPAA. So it's usually longer than exempt studies. In some sponsor, like drug studies, they might keep the identifiers for 25 years. So it varies quite a bit. Again, that they may need to keep them that long to verify the results, especially if they're trying to get a new drug application. These are some useful resources for what I've talked about so far. Secondary use guidance we have, limited data sets, and retention of study data, I think are good, easy to read guidance documents. A couple other areas that I see now and then are if you're collecting sensitive identifiable information, and there is a consent or a survey consent that's part of this. I like to see people clearly stating in the form consent form the nature of the sensitive questions. I know sometimes you get like, oh, they're asking really, when you read the survey that they've attached, or a lot of details, questions on drug use or sexual behaviors or whatever, your consent should say they're going to be detailed. They may be distressed, cause some distress from that, but they don't have to answer them. It's usually kind of something we look for is that you say you don't have to answer them, skip anything that makes you feel uncomfortable, because that can help mitigate the risk of them feeling this discomfort from that. Explain how you'll in the consent form, the survey consent form, how you're going to protect their patient subject identifiers. Consider transcribing audio visual records. Like if you have a Zoom focus group or something, consider that saying that you're going to be transcribing them and then deleting the actual recording once the transcription is made. And again, to protect their privacy, try to anonymize your data as much as you can. Let's see. And if you're every now and then there's a research study that involves students, and I like to see that, because I went through medical school and everything, that there's no that you have a plan, that you're not going to penalize any student who doesn't want to participate. There should be an alternative assignment. If the students in a class are not going to participate, they should not be penalized at all, but have a alternative assignment that is like fair and just with amount of time, effort required. And if it involves, the research involves studying beliefs or behaviors, develop a plan to safeguard the reputation or other ramifications if their answers were to be disclosed. And so that if, again, the consent form should state these things. Hang on. All right, I'm going to go on to full committee reviews. This is what Christine touched on, and I'm just have time for just a few points. Basically, they're more than minimal risk, like Christine said. Most of these are FDA regulated, but not all. There can be device studies where the risk determination needs to be made. Like if it doesn't have to go to the FDA for a determination for an IDE or investigational device exemption, then it might go to the full board to determine that yes, it's non-significant risk. And if it does not fit the criteria for exempt or expedited, then it would go to the full board as well. My take-home points are the consent form is a real key thing for the review. Sometimes these consents get up to like 40 pages and even more sometimes. And I know you put a lot of work to get as far as you do to put them in the application. And it's easy to just like, wow, we're done with this, attach it and move on to the rest of the application. But I find that if you could just take like one day to rest your head on that and then proofread it very carefully, it would help a lot. We look for if the form consent is correlating with the protocol in e-research and other documents, like maybe there be an investigator brochure for a new drug. Yeah, we look closely at that. I usually start with the protocol to read and see what this is all about. And then I look at the consent form to make sure that it's stating what I just learned from the protocol, basically. And so the procedures 4.1 and the risks in 5.1, those are the most common sections that we need to do some editing. I usually try to provide edits because I kind of sense of what they're trying to say. And I just want to make sure that it's clear to the person who is reading the consent. Like it could be your mom or your sister or something. So you want to make sure that it's written well and clear. One other thing, this is just certain tips I'm giving. So future use of data and specimens, it became more of an issue like around the time of the Common Rules updated in 2018. And so there's been a new consent template for the main consent, was put out a year ago, basically, and it's got template language for future use of data and specimens that you might want to include. And so basically from a board reviewer's perspective, if your research does hold the prospect of direct benefit to the individual participating, then future unspecified research that you're including the identification of this data or specimens, then that should be optional for subjects. And the reason is if the research holds out a prospect of direct benefit, like a new treatment or something, then you don't want to coerce people into signing up to like let you use all their data for as long as you need to, as long as you want, because they really want to get that benefit. So that should be an optional thing in the last part of the consent, an extra signature box. And now if the research does not hold a prospect of direct benefit, then it's okay if you research is really trying to get going on a new kind of a way to diagnose or treat things that you don't really have the prospect of direct benefit, then you could require that as a condition of participation. But the fallback usually have it optional, but that would be a situation where we could justify that fact that they're signing up for a study that's not going to give them a direct individual benefit, that they would know you're going to hang on to their data because you're still working out where this direction of research is going to go. Okay. All right. I think that's it for now. Thank you so much. Hope you're enjoying it so far.
Okay, so I'm going to hop in here and talk about the IRB HSPS, or the IRB Health Sciences and Behavioral Sciences Administration Office here at U of M. So the HSBS staff provided some slides for me to present, so I want to thank them for this material. But basically, I want to start out by saying that both IRBs are following the same criteria for approval. It's just the nature of the research is different for the two IRBs in most cases. And so the IRB HSBS has oversight for U of M Ann Arbor campus, Dearborn, and Flint, whereas IRB Med has overview of research through the medical school and the health system, and research that's FDA regulated and involves PHI. The HSBS portfolio consists of research conducted by investigators from a wide range of disciplines, departments, and units, including business administration, computer science, engineering, and law, dentistry, kinesiology, pharmacy, nursing, social work. Researchers from public health, psychology, and Institute for Social Research, those three groups submit 52% of the application. So they're the most active in terms of submissions to HSBS. HSBS has two boards named in maize and blue, and they each meet once per month. They also do expedited reviews, and so there are 5 faculty members and 1 IRB HSBS staff member conducting those expedited reviews. And again, as mentioned earlier, expedited reviews means that a qualified member of the board will to review that research project instead of it going to the full board, where there's a committee and voting on the approval of a project. And so in contrast, IRB Med has faculty members as well as 2 IRB Med staff members that conduct the expedited reviews. And so Kathy Dowling was one of those. Staff reviewers are assigned as liaisons for particular colleges and schools as well. So most of the studies reviewed by IRB HSBS are considered minimal risk. The primary risks are breach of confidentiality, harm to reputation or psychological well-being, social stigmatization, and discrimination. So those are different than some of the risks that the IRB Med office are evaluating in the research submissions. Roughly 1/4 are federally funded, so 60% NIH funded, 25% National Science Foundation, the Department of Ed, 17%, Department of Defense is 11%, and Department of Transportation is about 8% of those 1/4 federally funded studies. 80% of the submissions reviewed by IRB HSBS fall into the exempt eligible review, and 19% are expedited. Some typical review scenarios for the health sciences and behavioral sciences IRB, and the considerations that go along with those. So they review projects, for example, as autonomous vehicle research, and so the risks that they're considering are accidents and injuries to participants. Behavioral clinical trials often require ongoing monitoring, so they're considering that. There's community-based research where there might be community partners assisting in the conduct of the research, and so they have to consider when there is ethics training requirements for those community partners and how they'll go about sharing findings with the community when they're embedded in the community to conduct that research. Exercise, muscular strength, flexibility testing. There might be intensity that they're concerned about in terms of the activities that the participant are involved in, how they're determining eligibility to participate in those projects, and whether there's more risk to certain populations, and of course the potential for physical injury in the conduct of those studies. Field experiments and random control trials involving concealment and deception. The IRB has to consider when there is a need for alteration of informed consent to allow that concealment or the use of deception, and the debriefing process that would be required to notify participants of the use of concealment and deception after the study has been conducted, or at least after their participation has ended. Internet and social media research, there's privacy expectations in terms of use. Surveys might, and interviews on suicide, substance abuse, illegal activity, sexual behaviors. They're thinking about confidentiality and data security, potential psychological upset, and the need for support resources for participants. And again, all of these types of research projects could be scenarios or partly scenarios that the IRB is also looking at, but these are more common and very typical for the HSBS, and so they have a lot of experience with these particular considerations. Some special considerations at IRB HSBS. Like Kathy mentioned, research involving student records or students has its own set of considerations, but particularly for HSBS, there might be records and data from the institution that researchers are looking to access. So they have to apply and be aware of any research that involves extra protections from the Family Educational Rights and Privacy Act, or FERPA, which requires written permission for the release of information from student education records. So there might be some exceptions that apply under certain specific circumstances, but usually we want to make sure that there's permission for the release of identifiable data in student records. A memorandum of understanding, or MOU, may be required for the use of admissions and other academic data from the Financial Aid Office, from the Office of the Registrar, Learning Analytics, directly from Canvas if researchers are looking at class assignments, tests, results, and papers. 40% of the applications reviewed by IRB HSBS are for studies actually conducted by students. So student PIs must include a faculty advisor on their IRB application, and that's true for both IRBs. For all research involving a student or a trainee, there should be a faculty advisor on the application. However, sometimes students aren't receiving the instrumental support they need directly from a faculty advisor, such as assistance with the research design and planning, guidance on the preparation of the IRB application, and then help with monitoring the student researcher as they conduct their project. So our advice is for students is to really advocate for yourself and seek out that support from your faculty advisor. And for faculty advisors is to recognize the support that the students need when they're conducting those projects. So without that support, it can contribute to regulatory risk and the need for extensive support from the IRB staff beyond the standard human subjects training and education offered through peers and other educational courses and materials offered from the IRBs. Excuse me. So another consideration is a data use agreement, which might be required for secondary data analyses. If you're getting that data or sending data from U of M to another source or receiving data from an external source. So a data use agreement is recommended as a best practice for incoming data. However, it's the data provider that will determine whether a DUA is required. It is required, a DUA, when U of M investigators are sharing identifiable or coded data with an external institution. So these data use agreements must be executed. They're not executed from investigator to investigator, but by the institutions. You want to make sure you're contacting the appropriate offices to get those DUAs approved and executed. But investigators should not access or receive data until the executed DUA is in place. And the data provider is the gatekeeper to that data. So they shouldn't be releasing it until the DUA is executed. General considerations for IRB review, and so this is not just for HSBS, but generally. But the IRB is making sure that risk to subjects are minimized in the review and reasonable in relation to anticipated benefits of the research. Selection of subjects has to be equitable. Additional safeguards must be in place to protect the rights and welfare of any vulnerable subjects. Informed consent, when appropriate or required, has to be sought and appropriately documented, so unless that is waived by the IRB. And provisions are adequate to protect subject privacy and the maintenance of confidentiality of the data once it's collected. Some miscellaneous considerations. For if there's a specific sponsor, such as Department of Defense, these requirements must be met. The DoD requirements must be met if military or civilian personnel or facilities from any Department of Defense component are involved in the project. And for the Department of Justice, they are not a signatory of the revised common rule, so they apply the pre-2018 regulations. As discussed earlier, there might be novel apps and computers in play, sometimes considered FDA applicable, but when you have a novel app or computer software that is going to be on a U of M on the U of M network, you may require consultation with a security unit liaison and approval by information assurance. So that's another step that you might need to take. And then studies involving minors have to comply with the U of M minors in research policy. Prisoner research is subject to additional regulatory requirements. Subpart C of the regulations would apply. You would need permission from the prison and certification in some cases by the U of M assistant VP for research. Collection of identifiable data from participants located in the EU must adhere to the Global Data Protection Regulation, or GDPR. If the research is international, there may be a local ethics review required or other customary permissions. The study team's knowledge of cultural context would be an important factor in risk assessment for research conducted internationally. And in addition, the IRB staff must consider several issues that have not traditionally been part of IRB review, such as conflicts of interest, when export controls apply, intellectual property, and emerging technologies such as AI. So now we will move on to Q&A. And let's see. Stop sharing. And if we'll go to some of the questions that have been answered previously, just to recap for people who may not seen those, and then we'll go to some open questions. So just to first start out, if you've joined a little bit later, we are recording this presentation and we will post it and provide a link to that, and we will share the slides with everyone. Okay, so there was an early question when Allison was speaking about the definition of expedited category 1, which applies to devices. And so Allison responded that the regulatory definition of expedited 1 device is research on medical devices for which, 1, an investigational device exemption application is not required, an IDE, or the medical device is cleared, approved for marketing, and the medical device is being used in accordance with its cleared, approved labeling. So examples would be the use of physical sensors or imaging devices. Those types of uses would be potentially eligible for expedited review under category 1. And as we go through these questions, if you have follow-up questions or need clarification, please feel free to type those in Q&A. Another question about related to FDA is whether an IND or IDE is needed if the drug or device has already been approved by the FDA. And so it depends in the intended use of the drug or device in the study. So if you're using the drug or device as intended in its approval, as it is approved, it may not require an IND or IDE. If you're using it for a new indication or a new route of administration, so let's say something was approved for intravenous use and you're now using a pill form or a different it's compounded differently, then it would require, it could require an IND. My app is available through MISHAR to help study teams figure out when an IND or IDE is needed. So please contact my app if you have questions about drugs and devices and whether or not they need an IND or IDE. So while Allison was speaking, she also shared examples of algorithms being considered an investigational device. So there was a clarification question related to that. So there is a mobile medical app guidance. A link was shared. So we'll make sure to share that with the slides. But Allison also shared that software functions that provide periodic educational information, reminders, or motivational guidance to pregnant people, smokers trying to quit, or people recovering from addiction could be examples of algorithms used where they are considered a mobile medical app or a medical device. And then further, just to clarify, if the algorithm is designed to use for diagnostic, preventative, monitoring, or treatment purposes, and it is intended to have an effect on an individual's health, then it could be considered a device. And so there was a question during Nicole's presentation on single IRB as to whether the U of M has the authority to reject an amendment that's approved by the seated IRB. And so Nicole answered that. Do you want to take that one live, Nicole?
Yeah, I can.
Okay,
So
thank you.
essentially, the only way that we can reject an amendment is if that amendment in some way violates our local laws or institutional policies. Now, there is an exception because of study team members. We've remained responsible for the review of those qualifications and training. So we can reject a change to a study team addition or require additional study team support if we deem that it's necessary.
Thank you. Then there was a question during Christine's presentation about whether the consent form is re-reviewed whenever the protocol is amended to make sure it still follows the revised protocol, or is that left to the study team as a responsibility? So Christine, if you want to answer that one live.
If the changes that in the revised protocol, if they affect what the information that's in the informed consent, the previously approved informed consent, the consent form will need to be revised by the study team. It isn't something that is done as a pre-review or as a necessity. The study team needs to submit it. Now, if there are no informational changes in the consent form, but your footer information in the consent must match, let's say, the version of the protocol. When you change that footer, when you revise that footer, that new consent will still need to be approved by the IRB before you use it.
Thank you. Okay, let's see. Now we'll go to some open questions. And so there was a question during Christine's presentation about vulnerable population of women of childbearing potential. What exactly is the definition of potential regarding the vulnerability criteria? Is that determined by childbearing age, fertility status, etc.? So I just want to point out that by childbearing potential, it's just meant that the person is pregnant or can become pregnant. And so, Christine, do you want to further talk about that?
That changes with each woman. If a woman has the potential of becoming pregnant, doesn't matter their age in this particular case, then she is of that particular group. Julia, would you like to add to anything?
I was just going to say, sometimes we'll see a study where it's in menopausal women, that's their study population. So they're not of childbearing potential, so they would not check that. But But yeah, it doesn't really, there's not a lot of definition to it, but it's just think of is pregnant or could get pregnant. And if there's anybody in your study that fits those two categories, then check that box.
Yes, and so the consideration for the IRB staff and the reviewers is whether or not the particular procedures in that project would have a risk to a pregnancy. And so if a woman is or a person is of childbearing potential, they would need to know of those risks. And then there might be procedures such as pregnancy testing to make sure that pregnant women are excluded as recommendations for that project. So let us know if that's not answering your question, and we'll just move on to the next one. So if you de-identify your data for exempt or expedited, and then later would like to reanalyze that de-identified data, would you submit for secondary use for your own data, the data that you already have? So, Mary, the definition of human subjects research required to go under IRB review means that you're either interacting or intervening with live human participants, so you're surveying them, et cetera, or you're using their identifiable data or requesting to use their identifiable data. So if you have data that is completely de-identified and there's no link to identifiers, use of that data would not be considered subject to IRB review. So you would just want to confirm, you can confirm with the IRB that your data set is in fact completely de-identified and not subject to IRB review. There is an application in eResearch to do that. You could submit your project using a not human subjects research application and then get confirmation from the IRB that you do not need IRB approval for that project. If anyone else has a comment or a piggyback on that response, let me know. Okay, so there's another question regarding pregnant women or women of potential childbearing age. So if you have potential pregnant women or women of potential childbearing age, a vulnerable population, as your participant population of interest, what determines that they can be in an exempt or expedited project? So Christine or Julia, do you want to take that?
I can answer that. So what depends is what you're doing in the study. So I could have a population of pregnant women and I'm just giving them a survey, that's expeditable. But if I'm giving them a drug to see if it, helps pregnant women with their nausea, that's a drug study that's going to go to the full board. So I hope that helps. It depends on what you're doing in the study and if it meets those expedited categories. There may be some exceptions where, like I think Christine's in the presentation, like if the board reviewer feels like it needs to go to the full board, or if there's something about the study that needs full board, then that could determine it too. But that would be rare. Usually if it meets an expedited category, based on what you're doing in the study, it would usually be expedited.
Thank you, Julia. So there's a question about for exempt studies, how long can we store the identifiers? So Adam, do you want to take that?
Sure. So there wouldn't be any limitation, by virtue of the fact that the study is exempt. The interpretation would be the same whether you're exempt or expedited. But in general, I would defer to whatever the conventions are in your discipline, whether you're supposed to retain data for 5 years, 7 years. But I would just encourage you to propose to the IRB, tell us what you would like to do, if you would like to store identifiers and how long you'd like to retain them. And then we can work with you to make sure that any of the risks are mitigated, but you are allowed to do that. So.
And Adam, I think there's another question that you might be able to address. Someone asked if you could speak more to using community partners in recruitment and how this would be outlined in an application or protocol.
Oh, absolutely. So in sections 3 and 3-1 of the application, you'll have an opportunity to identify what are called performance sites and collaborating institutions. Performance sites are basically a physical location where research activities are taking place. For example, it could be a Michigan investigator that goes to a community location, but they're conducting the research. A collaborating institution might be the agency, for example, where your community partners are from, or whatever entity it is in the community. Um, but the key there is to let the IRB know whether they are what's called engaged. And engagement basically means that the community partner is either obtaining consent, they're interacting or intervening with subjects for research purposes, and or they have access to identifiable data. Your question is about recruitment, and recruitment would not engage the partners, although it's a good idea to still mention in the application their involvement. And it is in section 5. I don't remember the exact item number. I think it's 5.1.3 or, but uh, it's asking you about the expertise and the involvement of study team members, and there you can identify your community partners and, describe their role in recruitment.
Thank you. So there's a question about the process for getting undergraduate research assistants and account in e-research. So all undergraduate students should have their unique name, and that's all that's required to log in to e-research. But everyone, regardless of your status, it's faculty, staff, or student, you need to create an account the first time you actually log into e-research. So they can do that on their own. And then once there is a study that they need to be added to, the person completing the application could add the student to the research application. So they'll need to complete peers, as all researchers will need to do, and then they can just be added to the application. So let me know if that doesn't completely answer your question about undergraduate students. There's another question. What committee do we need to contact if we have an industry sponsor so that the data collected can be shared with the sponsor? And so that doesn't require any, so I'm assuming this might be a question related to like a data use agreement. So usually with the industry sponsor, you have a contract. And so that would go through the Grants and Contracts Office, separate from IRB review, but that's how that contract would get executed. Does anyone else want to jump in on that answer? Okay. So someone asked if they wanted to record a panel of a certain population of students to post on the social work website without having a full study. Do I need IRB approval? So I guess you might be recording. I'm not sure exactly what the panel would be and then what you would be recording them doing. So to determine whether or not it needs IRB review, you could maybe contact and call the IRB, contact someone by email and propose with more detail what you're planning to do. But if you're not doing research and you just want their permission to post them on a website, that would be outside of IRB's purview, but you may need to get their permission to post. So whether or not it's a research project is the question that we would need to figure out. So we would need more detail about that. But you certainly can contact someone in the IRB office or myself when you can provide more detail about what you propose to do. And so someone else asked if they wanted to do a survey of field sites for the School of Social Work to inform programming for the Office of Field. Do I need to submit anything to the IRB? So this might be like a customer or student satisfaction or things like that. So you still, again, can complete a application called the not regulated application or not human subject research application in e-research and submit what you propose to do. And that way, with all of that information, the IRB staff member can confirm whether or not that project is subject to IRB review. If it's quite simple, you might be able to ask the question in email, but the application is always there. And then that way you get a letter directly from the IRB confirming whether that it's not regulated for your records. Excuse me. So there was a question about the new application questions, any research regarding international research. We're going to have to come back to you on that, but we can provide that answer with the slides so that everyone is aware of that response. Okay, let's see. There's a question about information assurance or IA approval, whether it happens in tandem with seeking IRB approval, or does one come before or after the other? So IA approval or review is not required for IRB approval, but you do need to contact them. You might want to contact them before you submit your IRB submission in case there's some implication of whether or not you can use the software that you're intending to use. So I would contact them, and then you can find out how much you might need to interact with them before you submit to IRB. But certainly if you've already submitted to the IRB and then are becoming aware that you would need their review, you could still seek out that IA review at the same time. So it's not contingent on the other. So someone else is asking about training available, particularly for DNP students with a need for IRB submissions, and their projects are usually exempt. So I'm just going to put a plug in here generally for IRB courses that are offered monthly through the IRB Med Office. IRB HSBS also has courses that typically follows the student schedule. So they're offered less often, but they do offer classes as well. And then you can reach out to the education coordinators in the 2 IRB offices if you have specific questions about a particular program. And then we have a lot of written resources on the IRB Med website and the IRB HSBS website that might be valuable to your students. So if you're having difficulty finding particular resources, you can reach out to myself, Christine Polson, who's the education coordinator in IRB Med, or Adam, who's been speaking with us, who's the education coordinator for HSBS, and we'll be happy to assist to make sure that your students get resources. So we are over time, and so there's a couple more questions that we'll answer when we send out the slides to make sure that everyone has access to those responses. I want to thank you all very much for joining and spending your time. I hope there's a lot of information we covered today, but I hope it was informative and helpful, and I hope it gives you a sense that the staff in the HRPP, and particularly in the IRB, are here to help. And so if you have questions, if you need assistance, there's a wealth of information in our staff that can provide help, and there are a lot of resources that we have made available that we'd like to make sure that you have access to. So we will post the recording of this presentation and provide the slides, and continue to reach out if you have questions about submitting to the IRB. So thank you all. Thank you to our speakers. The presentations were great, and I hope you all have a good rest of your afternoon.